Dr. Masa, do you want to say something?
No,
Professor Anwar?
I think, yeah, I was unmuted. It's such a great pleasure to see Todd on this forum. And we really appreciate from the Pakistan Society of Gastroenterology and for Pakistani physicians. We are very keen to listen to all your expertise and, with my personal gratitude to you to be with us. And without much ado, I think we would love to hear from you about dealing with all the, which are all the complications of pancreatitis and all the fluid collections, how to deal with them. Thank you very much.
You're welcome.
Well, will please introduce him?
Yes, thank you. It's my pleasure to introduce Dr. Todd Baron, who is no stranger to any one of us in the field of ERCP, pancreatology, biliary diseases, and EUS, for taking the time on a Sunday morning to present to the Pakistan Society of Gastroenterology and the crowd that slowly but surely is growing. And now we have, of course, international attendees. So Dr. Baron does not need an introduction in the field, but just for background, he received his, and the crowd that slowly but surely is growing, and now we have, of course, international attendees. So Dr. Baron does not need an introduction in the field, but just for background, he received his, and the crowd that slowly but surely is growing, and now we have, of course, international attendees. So Dr. Baron does not need an introduction in the field, but just for background, he received his, and the crowd that slowly but surely is growing, and now we have, of course, international attendees. So Dr. Baron does not need an introduction in the field, but just for background, he received.
Musfa, there's something happening. We keep listening to the same thing again and again.
Yes, I'm not sure how that's happening, but I stopped talking a while ago.
Okay.
So briefly, so Dr. Baron got his medical school degree from University of Florida, Gainesville, and completed his gastroenterology training as well as internal medicine training at University of Alabama. He received the Alpha Omega Alpha Honor Society Award there, and completed his advanced endoscopy training at Duke University, following which he was an associate professor on faculty at University of Alabama, and subsequently moved to the Mayo Clinic, Rochester. After about 5 years there, he became a full professor and became the head of advanced endoscopy at University of North Carolina, where he currently practices. He has published extensively in the field with over 650 publications, and of course is well known to us from various societies. So thank you once again, Todd, for joining us and for providing your insights on this important and rapidly evolving field.
Thank you very much. Good evening to everybody there. The talk I'm going to give today is actually one that is I put together based on my experience as much as anything else. And it's I hope you find it to be very, very practical. The first thing that's important, we're going to talk about PFCs, or pancreatic fluid collections. So we'll use the abbreviation PFCs. There are types of PFCs that, unfortunately, even today, a lot of radiologists and a lot of gastroenterologists look at a fluid collection and say, oh, it's a pseudocyst. And there are many types of fluid collections, and this was published in Gut 2013 and hasn't changed. There's acute fluid collections. There are pancreatic pseudocysts, of which there are acute pseudocysts and chronic pseudocysts, and we'll get into each of these in a little bit later. And then there's pancreatic necrosis, which is further subdivided into acute necrotic collections and walled off pancreatic necrosis. So an acute pseudocyst, which we don't see very often, but arises from acute pancreatitis. And what we think acute pseudocysts occur is from very, very minimal, if no evidence of pancreatic necrosis and disruptions of probably a side branch that lead to a purely fluid-filled collection. So much in the way of what you would see with, for example, a bile leak, where you get a leak of, say, a side branch, but it's maintained because of the pathway of resistance at the level of the papilla. And this is an example of a patient that I treated many years ago that had what we thought was mild pancreatitis, gallstone, was discharged home and came back about 4 or 5 weeks later with gastric outlet obstruction. This was easily managed with placement of 2 plastic stents. The patient did well and had rapid resolution of this. Chronic pseudocysts, on the other hand, arise, again, they're completely liquidized or liquid, but arise from ductal obstruction and ductal hypertension. The ductal obstruction is almost always due to a stone, with or without a stricture impacted. And again, the ductal hypertension leads to what we call ductal blowout upstream to the obstruction. And again, this is a completely liquid form of a collection. So again, almost completely water filled. Here's an example of a patient with chronic pancreatitis, has a pseudocyst in the head of the pancreas, which you would think would not cause very much in the way of problems. But in patients with chronic pancreatitis, something as small as this can result in bile duct obstruction, which it did in this case, probably because there's also some element of distal bile duct narrowing due to chronic pancreatitis. So this ended up requiring management for biliary obstruction. Walled-off pancreatic necrosis, on the other hand, is an evolution of the pancreatic necrosis that occurred during the initial part of the presentation to an organized, partially encapsulated multiseptate state. And that's actually how we defined this entity when we first described it in 1996 in gastroenterology. It occupies and expands the pancreatic bed in the areas of acute necrosis. And we coined the term, again, back in 1996 when we published in gastroenterology. We termed this organized pancreatic necrosis to, again, distinguish this from the original pancreatic necrosis that someone presents with at, say, 24 to 48 hours to what they present with several weeks later. Again, this is now known as walled-off pancreatic necrosis. And schematically, or by illustration, this is what we're talking about, where the pancreas basically dies, as you would imagine. It almost always occurs at the junction of the head and neck of the pancreas and involves the body, but it can be any part of the pancreas. But you can see by this illustration, walled-off pancreatic necrosis contains elements of solid pancreas, where the pancreas has necrosed, as well as liquid that results from leakage from the disrupted pancreatic duct. And this necrosis can extend not only in the central part, as you see here, but often expands and extends either to the right or the left paracolic gutters, and it can go well down into the pelvis. But this is the typical central form of walled-off pancreatic necrosis. Now, I mentioned the term acute necrotic collection. By definition, an acute necrotic collection is this sort of organizing entity, but it occurs prior to 4 weeks. After 4 weeks, it's known as walled-off pancreatic necrosis. So again, these are the basic forms of pancreatic inflammatory pancreatic fluid collections. Here's an example of a patient. Again, these are all the illustrations I'm going to show you are cases that are my cases that I've done. Here's a patient that we treated with walled-off pancreatic necrosis, and what you can see is there's an NG tube in the stomach because the patient has gastric outlet obstruction. You can see the collection, and you can also see a little bit of enhancing pancreas. As most of you know, the normal pancreas with contrast, intravenous contrast, enhances in a manner that's somewhat similar to the liver and somewhat similar to the spleen, which you don't see here. But this area of necrosis is where a lot of the normal enhancing pancreas should be. Here's another CT scan of the same patient, CT image, which shows you some darker areas here, which probably represent necrosis. Now, the important thing to remember or to know is that CT scan is notoriously unreliable for revealing to you where the necrosis is, right? So you can see on the left panel, it looks very homogeneous. And this is the problem where a radiologist or somebody who's not experienced in pancreatic necrosis will say, oh, well, this is a pancreatic pseudocyst. And again, the problem is it looks very homogeneous. And you might say, well, yeah, it looks like liquid. Well, again, CT scan cannot reliably show you the necrotic debris. And often what happens is you might intervene on this and the patient may not do, may do well initially, come in with infection because you've now contaminated the necrosis. You've removed the liquid form through the stents, and then all of a sudden you can see a lot of air and you can see a lot of solid debris. So again, in the right panel where you see this, what may be more solid debris, may be a tip-off. The main tip-off that you're dealing with walled-off pancreatic necrosis, though, is how did the patient present? So if a practitioner or a trainee or a fellow or somebody calls me and says, I have a pancreatic pseudocyst, the very first thing I ask them is, well, wait a minute, how did the patient present? If they tell me, well, the patient was in the hospital for 3 or 4 weeks, they were in the ICU for a week, they're now doing relatively well, but they can't eat, then I know that this is necrotizing pancreatitis. You had a clinically severe episode of acute pancreatitis. So this arose from clinically severe pancreatitis, which by definition, clinically severe acute pancreatitis is as a result of necrotizing pancreatitis, and you're dealing with pancreatic necrosis. If you have an MRI, and we published this again more than 20 years ago when I was at UAB, MRIs in the T2 form can easily differentiate liquid from solid components, whereas CT scan cannot. But again, the clinical presentation of the patient will tell you often whether you're dealing with pancreatic necrosis or not. So I came up with this. I've never published this, but I came up with my overall view of pancreatic fluid collection. So we can put pancreatic fluid collections in many little buckets, but the bottom line is that it's a continuum that exists in a pancreatic fluid collection from liquid to solid. And some of them are completely liquidized and some are virtually entirely solid. But there is a continuum from liquid to solid. And there may be transition points in the degree of solid component that alters your management. So, for example, I would propose to you that less than 30% solid within a pancreatic fluid collection, for all intents and purposes, can be managed as a predominantly liquid collection. And let's say, for example, more than 60 or 70%, for all intents and purposes, you're dealing with something that has well into the solid component that needs to be managed differently. And then somewhere in between is going to manage now a little bit differently than either one of these. But the point being is that there are no data that can tell you where this transition point is. We tend to think, as I mentioned in the schematic earlier, that it's either predominantly one or predominantly another, and that may be true. But these are the ways I like to think about it in terms of how I need to approach a pancreatic fluid collection. Is it mostly liquid or is it mostly solid? So from my standpoint, if it's mostly liquid, you can use plastic stents virtually all the time and completely resolve the collection without much difficulty, or any self-expandable stent. And when I say any self-expandable stent, I mean even a biliary stent that's 10 millimeters will resolve a pancreatic pseudocyst, for example, that's completely liquid. If it's got moderate amount of solid, somewhere in between, you can use plastic stents with some sort of debridement, or you can probably use a large diameter self-expandable metal stent. And that doesn't necessarily have to be these brand new luminal opposing metal stents. When I say large diameter self-expandable metal stents, you can use even esophageal stents that are a short length esophageal stent if you have that, because obviously we were draining all these collections long before we had luminal opposing metal stents. And even in the years leading up to the point that we had luminal opposing metal stents, some of us were using short length esophageal stents to drain pancreatic fluid collections that had solid debris. But my point being is that in this middle range, that may be all that you need is a large diameter metal stent, and you might not need to augment that with some sort of debridement. If you have to predominantly solid, if you use any form of transmural drainage, meaning what we do endoscopically, I believe you're going to need debridement, okay? Because solid debris doesn't just fall out through stents, whether they're plastic stents or metal stents. The solid debris generally doesn't just fall away. It's adherent. And again, when you intervene on these collections, whether they're sterile or infected, you have introduced infection just simply by performing the procedure, because we are not performing sterile procedures. We're introducing contaminants through the mouth. And once you've intervened on these, if they were not infected, they are now infected. And then if you do not adequately remove the solid debris, you now have infected pancreatic necrosis. And we learned the hard way, way back when I started doing these. I got into this field by not understanding that I was draining pancreatic necrosis, thinking I was draining pancreatic pseudocysts, and in fact, then placed plastic stents, introduced infection, and then we had to deal with infected pancreatic necrosis. So you have to be prepared once you're intervening to evacuate the solid material. And again, going back to my simplified schematic, if it's minimal or moderate amounts of pancreatic necrosis, that's not that much that you have to remove. And then you can sort of get away sometimes with using just stents alone. But once you get into this point where you have a lot of solid material, you have to remove this solid material. It doesn't just happen spontaneously. So let's back up a second and talk about, well, what are our endoscopic drainage techniques? The endoscopic drainage techniques that we have available to us are transmural drainage, meaning that we puncture through the stomach or the duodenum, and that is typically called an endoscopic cystgastrostomy when you go through the stomach, or an endoscopic cystoadeноstomy when you go through the duodenum. And we have transpapillary approaches, or we have combined transpapillary and transmural approaches. So the techniques of pancreatic fluid collection drainage transmurally, all of you are aware of this, are now done primarily through EUS guidance. When I started doing these back in the early to mid 90s, I did not have EUS capability, and I would use a variety of techniques using standard upper endoscopes and duodenoscopes to blindly, if you will, puncture into these collections and to place stents. And then this again was long before we even thought about having luminal opposing metal stents. These can be done with EUS. Now they're done. We do them almost exclusively using EUS guided drainage, either with standard oblique viewing echo endoscopes, or in some cases, forward viewing echo endoscopes, although these are not used very often by any of us. So the vast majority of puncture sites have really become transgastric as opposed to transduodenal, and that's because people are very comfortable working in the stomach. The duodenum can be a little tricky in terms of the angles of approach, especially with an EUS scope. And because the majority of these collections arise either in the central part of the stomach, they can be punctured, or the central portion of the pancreas, they can be accessed through the stomach. But some are exclusively in the pancreatic head, and we drain them obviously through the duodenum. So the approach to EUS guided drainage is varied. And the reason I say that the approach is varied, not necessarily the puncture site, is it depends on the techniques. So we have a variety of techniques. The initial access, often when you're not using luminal opposing metal stents, for example, is an FNA needle with a guide wire. And then often that's followed by a cautery, especially when you're passing through the gastric wall. It can be difficult to pass a balloon over a guide wire without first enlarging the hole. So our approach is FNA needle, guide wire, and followed by passage of a cystotome over the wire. Although a cystotome can be used initially without a guide wire, and then a guide wire is passed through the cystotome. Likewise, you can pass a needle knife, a standard biliary needle knife, over a guide wire, or you could use a needle knife alone and then pass a guide wire. Almost all of us then perform a balloon dilation to allow a large enough opening to place stents through the gastric or the duodenal wall. And here's an example actually of a puncture that was through the proximal portion of the duodenum. And you can see, again, it's a little bit tricky because of the angles, but nonetheless, you can see a guide wire pass through the collection, balloon dilation into the collection, and placement of multiple plastic pancreatic stents. So typically we use double pigtail plastic stents. I almost always use 10 French stents, but if you have a completely fluidized, if you will, or liquid collection, you can place 7 French double pigtail stents. 10 French double pigtail stents are a little bit tricky to pass through an echo scope, but certainly I often use them with not much difficulty because I've become very, very used to placing large bore stents. The downside of placing plastic pigtail stents are they're a little bit cumbersome to place. With an echo endoscope, if you want to place 2 double pigtail stents, either requires you to double wire so that you can easily get the second stent in, or you recannulate after deployment of the first stent. Honestly, I usually will single wire. I'll balloon dilate to a diameter of at least 10 millimeters, whether it's liquid or solid. And then it's easy to just recannulate the opening to place your second stent. But if you don't use a fairly large dilation, it can be a little tricky with an echo endoscope to get the second wire back in beside the first stent. If you use a traditional covered self-expandable metal biliary stent, you have the advantage of a relatively large diameter, and you don't have to you can avoid placing a second side-by-side stent. So for liquid collections, let's go back to my Baron schematic of something being completely liquidized, which are pancreatic pseudocysts, of course. Plastic stents alone usually allow completely adequate drainage. It's very uncommon that you place 2 plastic double pigtail stents and you don't get complete resolution of a pancreatic pseudocyst. Self-expandable metal stents have not been shown to be more effective for completely liquidized fluid collection. So again, for pancreatic pseudocyst, self-expandable stents of any kind have been shown to be more effective than plastic stents, and obviously there's the cost associated with them. Luminal opposing metal stents, which have become very, very adopted in the United States and embraced in the United States with an enhanced electrocautery step, allow for entry and stent delivery in one step. So what they've done is they've saved a lot of time and avoid a loss of access. So as you know, when you put a fine needle aspiration, a guide wire, every time you do an exchange for another accessory, a balloon, or even during stent insertion, there's the possibility that you might lose access and have to start over. So the luminal opposing metal stents, while they save you time because they're fairly easy to deliver and avoid loss of access, again, I want to emphasize they've not been shown to be more effective, at least for simple, completely liquidized fluid collections. I won't get it. I know that because you don't place a lot of luminal opposing metal stents. I can tell you, though, in my experience, I routinely place a plastic stent within any self-expandable metal stent for pancreatic fluid collection, although that's a little bit controversial. And the diameter of a luminal opposing metal stent is what I call dealer's choice for my Baron type A collection. So a completely liquid collection, it doesn't really matter if you use a luminal opposing metal stent or a self-expandable metal stent. You can choose whatever diameter you want, because those will resolve completely with any self-expandable metal stent. All of you are aware of the luminal opposing metal stent that's available in the United States. There are others available outside the United States. This is the one that has the electrocautery enhanced tip, allows guide wire placement, and has a short length of either 10 or 15 millimeters and diameters of 10, 15, or 20 millimeters. And this is the one that's used in the United States. Again, you can see here, the main reason that I place a plastic stent through these is my concern on the edge of this stent impacting against the opposite wall of the collection. As it collapses, there have been reports of stent-induced bleeding, which I think, in my opinion, without scientific data, might be prevented or lessened by placement of a double pigtail stent through this, since it might prevent the wall of the opposite wall from collapsing down against the edge of the stent. But that's, again, unproven. So here is a completely fluidized collection. This is one of the ones I drained early on when I first started doing echo endoscopy back on my own in about 2014. And this was actually using the forward viewing echo endoscope, which I don't use nearly as much as I did when I first started. This is a placement of a 10 millimeter Axios over a guide wire in a completely liquefied pseudocyst. You can see I was close to the pylorus, which is on the lower part of the screen. Here is the marker that tells you that you can deploy on the luminal side, and here is the fluoroscopic image with the immediately deployed stent, which has a nice waist in the middle of the stent. So let's talk about what I call the Baron type B's and C's. Those are the ones that either have moderate amounts of solid debris or a large amount of solid debris. So on these types of collections that you will not drain through the papilla, you perform transmural drainage. I tend to, when I use plastic stents, I tend to use a large dilation. And the reason for that is that I like to get as much liquid and solid debris out during my original drainage. So it's not necessarily that I'm dilating it large to get the stents in, but I'm draining it as a large amount to get a lot of fluid out and actually to drive into this collection so I can perform debridement. So there are a variety of debridement methods. So again, we're dealing with something that has a moderate to large amount of necrotic debris. And as I mentioned, just by simply placing plastic stents often will not allow this to resolve on its own. So your debridement methods are either irrigation or direct endoscopic necrosectomy, or some combination of irrigation and direct necrosectomy. So when I published on this in gastroenterology in 1996 on endoscopic therapy for what we again termed organized pancreatic necrosis, the way that I was able to resolve these is with an irrigation system. So in all the cases that I published for many years, I described placing using a standard nasobiliary tube that you would use for ERCP. We would call that a nasocystic drain. We would dilate this tract opening to a large diameter and would place 2 plastic stents, and then we would irrigate aggressively through the nasocystic tube to remove the solid material. This was subsequently described a multi-gateway theory or multi-gateway approach by Sham Verdergerlu, which I know I didn't say that correctly. We call him Sham, or we call him V, who most of you are familiar with. And the multi-gateway theory is really just the same concept, but rather than one puncture site, there were 2 puncture sites with placement of a nasocystic tube through one of the puncture sites, but with plastic stents placed through all the puncture sites, so that you would get inflow of the fluid and the through one site and the outflow through another site. But again, irrigation to allow for debridement of necrotic debris. Direct necrosectomy is something that I did a lot of. I started probably doing this in around 2002 when it was, I was not the first to publish on this. It was first published in Europe, but it was something that I popularized because patients don't like having tubes coming out of their nose. They don't like to care for them. They don't like to go home with those. So I started performing direct endoscopic necrosectomy. So direct endoscopic necrosectomy, I would often do on the original puncture through the gastric or the duodenal wall. I would dilate the opening to a very large size, usually 15 to 20 millimeters, and drive the standard forward endoscope inside the necrotic cavity to debride the necrotic material. Again, this is one of my patients from way back, and this is an excellent demonstration of what I talked about with necrotic debris and a CT scan. So this is a non-contrast CT scan. You can see this collection, but what's important about this collection is it contains non-dependent air. So if this was fluid, you would have an air fluid level, as you would expect. But when you have solid material, you don't have an air fluid collection. You have air that's dependent, it's trapped. So it can't float to the top. And you can see that the density is very non-homogeneous. So we know this is a walled off pancreatic necrosis. In fact, in this case, I could have gone transgastric, but I actually went transduodenally. And this is when I was using, without EUS, I was using a dedicated 19 gauge needle that's not on the market anymore, that I would puncture, inject, and you can see all this solid material. And I would dilate these tracts to 20 millimeters on the first pass and drive a forward viewing endoscope inside the cavity. And you can see this is inside the cavity. Here's another, a different patient where I was actually able to get out completely a large amount of solid debris. Here's a different case where I removed a large amount of solid debris in one piece. Here's another case that I was able to remove a large amount of solid debris. But I can tell you these are very labor intensive procedures. And I'll give you an example. Here's a case of a large walled off pancreatic necrosis that was extended all the way down into the pelvis. You can see this is actually my second procedure, balloon dilation, driving into this cavity and performing direct endoscopic necrosectomy. I still perform some direct endoscopic necrosectomy, not as much as I used to, because I think with luminal opposing metal stents, we have tended to perform less direct endoscopic necrosectomy than we did in the past, but it has gone completely to zero. But you can see I'm pulling out a large amount of solid material from this collection. Often you don't get one solid piece. I don't normally take them all the way out of the patient, but it always makes for a good photograph if you take it out. And then you can see I got the collection resolved and placed again 2 double pigtail stents through the posterior gastric wall, and this led to complete resolution in this patient. This is we touched upon use of self-expandable stents. If I use self-expandable metal stents, wall-off necrosis, whether it be esophageal stents or luminal opposing metal stents, I almost always use 20 millimeter, but 15 if I need a slightly longer stent, because those 15 millimeter stents also come in 15 millimeter lengths. I won't delve too much into the literature. Most of you are familiar with the literature. This dates back to 2016 of one of the larger initial reports of use of luminal opposing metal stents for walled-off necrosis with high technical success, clinical success, a relatively low need for percutaneous drains, and still required direct necrosectomy. So for the Baron type B and C collections, the bigger the diameter stents, the better. When lambs are used, I prefer the 20 millimeter stents. In some cases, debridement methods may not be needed when using large diameter stents. And again, this goes for esophageal stents as well. I tend to use large diameter stents alone as first line therapy, but I use debridement for poor response to SIMS alone, or if I'm using plastic stents, debridement methods are needed. The large, what I call the C-type collections, are large collections, and those with greater than solid, more than 60% by MRI or EUS. Again, I use large diameter SIMS, or with planned debridement as part of my strategy, whether it's at the first intervention or later. Again, whether to perform direct necrosectomy up front or at the time of a second planned procedure is not entirely known. Use of hydrogen peroxide may facilitate subsequent debridements. There are several studies now on the use of hydrogen peroxide, which is inexpensive. There is a publication on hydrogen peroxide recently published in the American Journal of Gastroenterology from Emory University primarily, and I wrote an editorial on that as well. I know we're getting close to the time where we're going to do questions and answers. This is just a demonstration that direct necrosectomy is often needed when there's a large amount of necrotic debris, and it can be performed, of course, through the luminal opposing metal stent, although there is a risk for dislodging the stents when you are grabbing a piece of necrotic debris that is larger than the diameter of the stent. Obviously, there's going to be a fair amount of friction in removing the stent, or removing the debris through the stent, which risks having the stent come out. And that's why if I'm going to perform debridement, even if I know that's part of my strategy, I tend to wait until the subsequent procedures, because I think, although I can't prove this, that the risk of dislodgement might be less after the stent has had a chance to fully expand on its own and sort of seat within the tract. But again, we don't know that. There's not evidence to prove that. Here's a subsequent CT scan. Again, minimal residual necrosis within the residual collection. I want to touch on something called dual modality drainage, which was popularized and is used in some centers, was popularized at the Virginia Mason Medical Center. And that is what they popularized was sending the patient to interventional radiology to have a percutaneous drain placed with minimal amount of fluid removed. And then the patient would be immediately sent to the endoscopy suite for drainage transmurally. And the idea here is that the CT guided catheter is not used as a method of removing liquid or solid, but it's used as a method of irrigation rather than have something go through the patient's nose. You can do aggressive irrigation, which again passes into the collection and then out through the stomach as a way of managing these types of collections with transmural plastic stents. They did the same group actually published and showed that in their mind, or in their practice, luminal opposing metal stents didn't appear to significantly improve the outcome over plastic stents when dual modality drainage was used. So in that practice, if they do use dual modality drainage, they tend not to use luminal opposing metal stents. So again, in treatment of symptomatic walled-off necrosis, LAMS did not shorten time to percutaneous drain removal and was not associated with fewer adverse events. So I'm about ready to summarize what I've told you here today. The sort of the Baron, unproven Baron schematic, which is again, fluid collections can range from liquid to solid. We know that to be true. I tend to, in my mind, not think necessarily as much about what are they, but what do they contain. If they're almost predominantly liquid, you can use plastic stents without any problem. And probably any self-expandable metal stent of any diameters that will resolve these without any other augmentation. With moderate amounts of solid in this B category, plastic stents with debridement or large diameter stents perhaps alone. And then if it's in this category where it's predominantly solid, large diameter self-expandable stents with debridement is my preferred. Although if you don't have that, of course, you can use plastic stents with augmenting with either irrigation, as I first described, with nasobiliary tubes or nasocystic tubes, or augmented with percutaneous irrigation or with direct endoscopic necrosectomy. But it's imperative in this group that you do some sort of debridement technique because stents alone will not allow you to resolve the collection. So I'm going to wrap it up and allow us a little bit of time for discussion that pancreatic fluid collections can be liquid, semi-solid, or entirely solid. The approach can be stratified based on the degree of solid or liquid component. Endoscopic drainage of liquid collections is very straightforward. The endoscopic therapy of walled-off pancreatic necrosis may be complicated depending on the degree of solid component. And the transition points that I've proposed to you, where it clearly is going to change management, need to be determined using science. But I think in my my limited stratification, I think you can at least use that in your own practice of less than 30 to 50, and probably more than 60% in terms of solid debris. And I'll stop now and feel free to ask questions. Thank you very much for your attention.
Thank you, Dr. Baron. This was excellent. I'm sure that there are a lot of questions. I have a couple of questions with some personal experience also. During the necrosectomy, there are a lot of bands or strands which are vascular. Is there a way you can burn them off or prevent them from bleeding? And if there is some bleeding starts, do you have a way of packing it or any way to stop it?
Right.
That's one. And the other one is about pseudoaneurysm. which do form and they can be catastrophic? And how do you keep us alert from the event when it happens and the IR people to be accessible or not accessible?
Right.
How do you deal with that in your center? Thank you.
Yeah, very excellent question. Unfortunately, I rely, and I think most of us rely on what it looks like visually. Those of us, as far as the bleeding vessels that you described, most of us have gotten to the point where we can detect sort of subtle, nuanced things that may predict their underlying vasculature. But unfortunately, we can't always predict that. I've been very fortunate to have minimal bleeding episodes. Fortunately, none catastrophic, although I've had some that have been scary. So I'll talk about managing that. If that occurs, we tend to fall back on what we know we can do for treatment of bleeding. Of course, if you get into a massive vessel and the patient is exsanguinating, there's not a lot you can do. Most of the bleeding that I've gotten into has been brisk, but not catastrophic, that I've either been able to use cautery. I've actually, in some cases, and I have some videos that I've never shown or edited, I was able to use clips. So generally speaking, you can use more typical endoscopic methods. But in the catastrophic case, as you mentioned, if you got into a branch of the splenic artery, then you would most certainly need to get the patient stabilized as quickly as possible and get them to vascular interventional radiology. We did have one patient at Mayo that the collection actually eroded into the portal vein. I actually wasn't the one that was doing the debridement, but the patient survived. There was not a lot that interventional radiology could do. It stopped, but the patient ended up going to surgery. Well, it didn't actually, it didn't catastrophically bleed. IR couldn't do much, and the patient actually had to go to an open surgery and ligation of the portal vein. Again, fortunately, those things are very, very uncommon, but your point is very, very well heeded in that people have to be aware of that being a potential life-threatening or lethal complication. As far as the pseudoaneurysm goes, I think that it's good to have a very, very up-to-date cross-sectional imaging study with contrast before undertaking your debridement, if at all possible, that might be able to help you detect a pseudoaneurysm before you undertake the procedure. And of course, those patients do very well if you prophylactically embolize, have your radiology specialists embolize those, and then it's safe actually to go ahead and do your either, whether it's a pseudocyst or a necrosis, to do your intervention, because once it's embolized, that risk is gone. But unfortunately, I know people might have used endoscopic ultrasound within the cavity at times to identify potential bleeding, but that's difficult and cumbersome to do that. But I'd like to hear Mustafa's comments in that regard, if he has any other additional comments.
Oh, thank you, Todd. No, I totally agree. I think an up-to-date CT scan with looking for pseudoaneurysms is helpful. I've had it both ways, where you find it and you address it, or it's so subtle that we don't see it, and then once we intervene, then they bleed. And fortunately, IR tends to be quite supportive. And the smaller vessels can be tricky. Again, clips, cautery.
Right.
Hemospray, I've now tried a couple of times, but those are as you said, persistent but small bleeds. And getting the eyes trained to recognize the bigger vessels, as you said. So I completely sort of agree and appreciate you commenting on that.
Thank you.
How about in the setting of the type B/C? Are you now still doing with the Lumina? I know this is primarily a US based question, I guess. Are you still doing nasocystic drains with the lumen opposing stents, or have you?
I do not. I probably haven't put one in a long time. And if I do, it's very selective. It's usually going to be an inpatient that I do that on, that maybe I wasn't making as much headway as I would like to. And again, patients really don't like it and don't like having to go home and actually take care of it on their own. So let's say I have somebody that's been in the hospital for a long time, that's really sick, that is not going to be discharged quickly. But in general, I've been using exclusively the large diameter luminal opposing metal stent, and then reserving direct necrosectomy as my method of debridement. Obviously, there are patients that still need adjuvant percutaneous drains that have more peripheral extensions, that you might be making a lot of good progress on the central part. We know they communicate, but often what happens is they communicate with the more peripheral down the paracolic gutters and into the pelvis, but you don't get the adequate enough drainage from the central part. And so in those cases, we often rely on interventional radiology to place percutaneous drains to irrigate those back into the main part of the cavity, but less on the nasocystic than ever for me personally.
Two very
Great,
basic
thanks.
questions. They have been highlighted in the chat box. Do you use PPI in patients who have been punctured for cystogastroscopy?
Good question.
Right.
Right. Excellent
And
question. Right.
Do you give antibiotics, and why, and how long?
Great. Both are excellent questions. So we all in the field believe that it's better to stop acid suppression because we think that acid egressing into the collection can act as its own way of debriding or breaking down the necrotic tissue. So the general recommendation, without a great amount of scientific data for support, is in fact to stop acid suppression, even if they have some esophagitis, which often is because they have gastric outlet obstruction from their collection and reflux. In terms of antibiotics, absolutely, I give antibiotics up front, and I continue antibiotics. I personally think that these patients need to be on antibiotics up until the point that it's almost completely resolved. I get into arguments, never had arguments when I used to manage these patients alone, but often my infectious disease experts say, well, you don't have data to support antibiotics. But as I mentioned to you, we're introducing infection into these collections. They're not sterile anymore. So I tend to put them on broad spectrum antibiotics for at least several weeks. But I've had other people come behind me and say, well, we're going to send them home without antibiotics. And I've noticed anecdotally that they tend to get, even with good drainage, and they still have residual necrosis, it's infected at that point. So I tend to keep them on. And my recommendation is longer periods. I usually will use something like Levaquin with or without something else like Flagyl. I used to use ciprofloxacin and Flagyl together. Sometimes I would add an antifungal agent, but it's usually just single agent levofloxacin for at least several weeks. Anybody else have a comment on that?
Nusra and Vasa, do you have any comments?
Todd, hi, it's Nadeem Tahami. I practice in Southampton, UK. I completely agree with you. In fact, I was going to ask you a question on that. And my question is, do you aspirate these cysts or collect the fluid after drainage and send it off for the microscopic culture or not? Because there's obviously a concern about orogastric fluid contamination.
Right.
Having said this, our practice has been, so we do about sort of 50 of these a year. Our practices, we usually send the fluid. And I think initially for the first week or so, we give the empirical antibiotics, as you were suggesting, followed by the guidance that we received from our microbiology department. So that is our practice, and I'll be keen to hear what your view on that is.
Excellent question also. So if I intervene and we're all convinced this is sterile, right? They have gastric outlet obstruction, no fever, white counts normal, but we're draining what we think is a sterile collection. I don't aspirate those because, as you mentioned, I think you get spurious contaminants. If we all think and suspect that this is clearly infectious, I will either aspirate with a needle, or once I put a large diameter stent, I put a trap on, suction it, send it. Then what I tend to do is say, look, if this is clearly just an oropharyngeal contaminant, I ignore it. If it's something that shouldn't belong in the upper GI tract or the mouth, Enterococcus, Pseudomonas, some of those things where you say there's no way this is something I introduced, then clearly that's very helpful to guide antibiotic therapy. So I think you have to be selective in your interpretation. Obviously, the gram stain will help, because if we probably do a contaminant, they're not going to be 4+ whatever that organism is in the fluid, and the real pathogen should at least often come out in the gram stain and then be proven by culture. So I think you have to interpret it yourself a little bit about what it is you're growing out of the collection. So again, if I think it's sterile, I don't even send it, because it'll be, if it's positive, it's going to be a spurious, and then some people may end up chasing that for no good reason.
Todd, very quick question about if you have any fistula formation, which is not uncommon, enteric fistula, or when the radiologist put a drain in, do you treat them with octreotide, or how do you deal with these long-term fistulas? Or
Right.
do you put a stent in the pancreas to sort of
Right.
stop?
So your point is also, again, excellent question. So the problem is that if a radiologist intervenes before you do, or does the entire intervention percutaneously, which I have no problems as far as, it's not a turf war, but if they drain a collection, as you mentioned, that then communicates with the main pancreatic duct, which often these do, at the end of the day, you're going to end up with a pancreatic cutaneous fistula. If there's still some residual pocket you can drain, then the way to do that is to get stents transgastrically or transmurally into the collection, so you can divert that internally. And then you always want to get their drain out before you take yours out, obviously. So that way you avoid an external fistula. And by having primarily internal drainage, it'll close from the outside. The problem with doing a pancreatic stent, sometimes it's a very good option, but if you have a disconnected pancreatic duct, and this is the problem with, if you wait a long time and then somebody calls you and says, radiology resolved this, can you fix this? And they have a disconnected pancreatic duct from necrosis, and you do an injection, you can't access the area of the fistula. And then you have to become a little bit of ingenuity, because if there isn't a clearly defined large enough collection to go after, you have to do some EUS therapies. You still do it transmurally when you can. What I have done and reported, and others have as well, is you take your EUS needle and you have to directly puncture into whatever small drain or drain tract that they have with your EUS, and then place stents into that tract, obviously not coming out to the skin. And it's the same way of internalizing the fistula internally. I don't want to take too much time, but if we have a little time, the other question about a fistula, which I think is very interesting, is the classic textbook teaching of somebody who comes in with air inside a collection on CT that's never been instrumented is, they have gas forming bacteria that are creating air. I absolutely don't believe that to be the case. I think that when you get air, it's because you've fistulized somewhere to the GI tract. Now that then brings in infection, but it's not that the bacteria produces the air, it's the fistula to the GI lumen. So we've all seen patients that show up for a CT scan and they have air in it, and they're perfectly look great. They absolutely look 100% great. Everybody, goes crazy and says, "Oh my gosh, there's air in there." Those are usually, in my experience, in the upper GI tract because there's not a lot of bacteria. So they're either usually somewhere in the duodenum where there's not a high bacteria content. And I say, look, if the patient looks well, don't do anything rash. If they don't look bad, but you want to drain it, often you can find the fistula in the duodenum and actually use that as your entry point right into the collection. If they have air and they look absolutely terrible, in my experience, it's because they fistulized to the colon. So then they're bringing in horrible bacteria from the colon, and they tend to be extremely sick. And they are the most foul smelling things you've ever done when you drain these, as you would imagine. And it's funny because in my, this is my interpretation, my brain, they don't smell like stool. In my mind, they smell like burnt rubber. As weird as that sounds, it's a very, very unique, distinct smell. And they tend to be extremely ill patients with very high white counts and very foul. But that's my personal opinion on spontaneous air inside these cavities. I think it's almost always there's a fistula somewhere to the enteral tract.
Todd, there are three questions. One, Dr. Ali has put up in the question answer session. How do you clinically and radiologically differentiate between a simple walled-off pancreatic necrosis and infected pancreatic necrosis in an unwell septic patient ICU with multiple lungs, catheters, collapse and consolidation of the lungs, and other potential sources of sepsis as well?
Yeah.
When will you intervene for pancreas in such a patient?
So let me say up front, some patients you just won't know until you actually go and do an intervention, right? Because some patients are systemically ill, as you mentioned, other sources of sepsis in the ICU, inflammatory state, those things that can make it very, very difficult to distinguish infected from sterile. And that's something that we've all grappled with for many, many years. The kind of case where, let me go to the other extreme. So there are two extremes, right? There's the one that they had their necrosis, they're getting this big collection, they can't eat, they're talking to you, they don't have a white blood cell count, and you intervene because it's just, they just can't eat. Okay, that's one, that's clearly looks like sterile. The other end of the spectrum is the case that tends to be more obvious is they had necrosis, they were doing really well, their white count resolved, they're actually going home, and they represent, and all of a sudden they now have new onset fever to 102, 103, and their white count, which had previously normalized, is now 25,000 or some very, very high number, and maybe they have air in the collection. That's the other extent where you can say, okay, this clearly was probably sterile, now infected. But as you mentioned, there's there's some people in the middle who have sterile necrosis, not doing well. You can't tell. In the old days, and I mean the old days, maybe 15, 20 years ago, we were doing a lot of CT guided fine needle aspiration to have the radiologist go in and aspirate the fluid, send it off, and tell us whether it was infected. And that was popularized by Peter Banks. It's fallen out of favor some ways because there are false negatives, there are false positives. Sometimes, in fact, the radiologist goes through a loop of bowel and not only gets infection out of it, but contaminates the collection on the way in. My point is that sometimes you just can't tell. And if you have something drainable, you may just have to go ahead and do an intervention, understanding that that may not be infected, but you have to go in and do an intervention to see if you can get the patient better clinically. And that's the best that I can offer. Mustafa, do you agree with that?
Yeah, I agree. I think there are those where you just cannot differentiate systemic sort of ongoing systemic sort of disease versus infected necrosis. And again, similar to your concept where you have a fistula where they're presenting with infection and the gas is because of the fistula. I think there is a component where you have ongoing infection which we can't prove, but it's causing multi-organ dysfunction. Those are the gray zone ones where you 4 weeks, 5 weeks into it, they're not presenting like it's abrupt change in status, but a persistent unwell state, as it's been described in some sort of some documents, where it makes sense now we should intervene. The renal functions are improving. They're still like in the ICU. They're not able to leave the floor. I think those are the trickiest, but at the same time, I, again, not published, but anecdotally, I would say those are the ones when you intervene, for the most part, they tend to improve. And think there is low-grade infection that we're just not picking up with our tests.
Right.
And may I extend on that point a little? I think the importance here is those patients on intensive care with multi-organ failure. So if we talk about the acute necrotic collection, which hasn't got a true wall formation at a stage, and they're still under 4 weeks. But if they've got an evidence of ongoing multi-organ failure, that is an indication on its own to intervene as well. Now, I think there is a paper out there, I think about 2 years ago, again published in American Journal of Gastroenterology, where they looked at intervention before 4 weeks and the formation of the wall. And the outcomes were pretty much similar. In fact, patients did really well. So I think that point also been kind of taken into consideration. Patients who are really sick and they've got a pancreatic fluid collection, whether it's acute necrotic collection or walled form, walled-off necrosis with ongoing necrosis, I think it's an indication for intervention.
Yeah.
No,
No,
go
ahead. Go ahead.
Yeah. Sorry, but you're saying something.
Oh, yeah. I didn't mean to interrupt you. I was going to add to what was just said is sometimes we intervene earlier than 4 weeks, and I'm okay with that as long as it's organized and right. And so, or you can tell by looking at the CT if it's just sprawling solid everywhere, that's not going to be amenable to at least what we do. But some people, even early with these acute necrotic collections, will organize their collection. So I don't have a problem with going in earlier if there's a high suspicion that it is infected. I agree with what you said, but it's the morphology of what it looks like on cross-sectional imaging.
Absolutely.
Do you use any clinical imaging or endoscopic criteria to evaluate whether the necrosis is under control after your intervention?
Well, so obviously we combine serial imaging with their clinical after we've done our intervention. In my early days, I tended to probably re-image more quickly than I needed to. Realizing now as you get older, right, you take it easy a little bit more, that the things aren't going to change overnight in a necrotic collection. In a purely fluid collection, it's amazing. You can get a CT 3 days later and it's literally almost gone. But in a necrotic collection, we know it takes a long time for these to get better. So if the patient's clinically doing well, I say, look, don't re-image them, sooner, unless you think that's going to change what you're going to do. Like if you say, well, do I want to quantify how much solid debris is left? But if the patient's clinically doing well, they probably don't need an intervention. So I can't give you a number, but I tend now not to get a CT earlier than say 2 weeks to 4 weeks, whereas before I was almost getting them weekly. But I'd be interested to hear from Mustafa or anybody else how they do it.
Yeah, again, I've backed off of it, especially when I go in there and I see, there's going to be necrosis once you drain them and there's necrotic debris coming out. And as you said, your clinical suspicion is high. The whole we're going to go back in 4 days, let's get a CT before we go in. I've definitely backed off on that.
Yeah.
Interestingly, we've just submitted for publication a manuscript looking at radiation exposure for necrosis patients. And it is insanely high to the point that I'm trying to back off even more. I think, as you said, certain things, Dr. Anwar's point about fistulas, things like that where you want to do targeted imaging, I think it's really helpful. But for the most part, doing it on a more absolutely necessary approach versus just doing it for the sake of seeing how is the necrosis looking, 4 days later.
Exactly. Yeah. And to your point, just to add to that, I'm getting more MRI than I used to. My only frustration with MRI is I can't read it as well as CT.
Exactly.
Right. So you
Yes,
tend to get a
absolutely.
CT, but on the other hand, it's probably better for the patient in terms of the radiation exposure that you mentioned.
Absolutely.
We talked about the interventions. Are there any pancreatic cysts, the pancreatic fluid collections, which you'll not like to intervene?
Well, I think the first thing, a couple of excellent question. A couple of things. Number one is we always have to keep in mind that what we do on a pancreatic fluid collection is for symptom or infection. So that if the just because they have a really ugly looking CT, for example, if the patient is doing relatively well, we shouldn't just go in because they have a big collection. We've all seen patients that are getting better slowly, but it's sterile and they're able to eat. I've turned away patients that were specifically referred to me for drainage that were sent specifically for me to drain. I had to talk them out of it to say, look, yes, we can do this, but at the end of the day, am I going to make you better faster? Which is what we're doing. We're either going to do an intervention to make you better faster than natural history, or because it's infected and you're going to die without an intervention. So part of it is to always use your clinical judgment and not just drain something because the CT looks bad. Two is we didn't discuss is you always have to make sure what you're draining is actually an inflammatory pancreatic fluid collection. We've all seen patients refer to us with pseudocyst or something to drain that's actually not. It's a pancreatic neoplasm, a pancreatic cyst. So you should always keep in mind that you should always rethink every single referral that comes to you that maybe this isn't that. So I can give you at least 3 examples around my career pathway. One was I was only a few years out of fellowship, and somebody said, "Oh, I've got an 18-year-old who got a spider bite 8 weeks ago. He didn't seek treatment, and they've been reading textbooks, and they tried to talk me into a brown recluse spider bite, and the textbook pancreatitis that he never had, and he's got this pseudocyst." And I'm like, "Oh, sure, whatever." So I go in and drain it, and then 24 hours later, he's got a perforation because he has a gastric duplication cyst. And that was when I was using plastic stents, and it just separated off the duodenal wall or the gastric wall. I've been sent cystic neoplasms, a mucinous cyst on a woman from a pancreatologist I won't even name way back. They said, this is absolutely a pseudocyst, drain it. It wasn't. So I want to say that if you don't have evidence that the patient clearly had pancreatitis or has evidence of chronic pancreatitis, then you should always think, is this something else other than a pseudocyst or something like that you shouldn't drain? So those are the two things that you ask me, or at least that I would think of when you ask that question.
Prasanna, you wanted to say something? Todd, there are a number of cases who come, for example, in our country, there are people who live far away from medical help. And at times they come after 2 years or 3 years of fluid collection, it's all thick wall. Would you like to intervene in that?
Yeah, we don't see that as much here. But having said that, it's interesting you bring that up. I'll never forget a lecture by a guy that was early on, who was actually the main driver of the first Atlanta symposium, and I'm blocking on his name, but he was a surgeon from Atlanta. That's why it was the Atlanta Symposium. And he showed a case of a necrotic collection that persisted. And they did actually a biopsy of it, and it was completely fibrotic, and it never resolved. And so to your point, I think that the ones that have been there a long period of time might be something different by that point than what they were a couple of years ago, even if they persisted. And it goes back to what I was saying, and that is that if something's been there a long period of time and the patient's done reasonably well with it, even if it persisted, that's not by itself an indication, I think, to drain. But to your point, I think the wall is going to be thicker. The material may be different inside of it. It's hard to know. People always assume that these these things liquefy over time. But the point I was trying to make with what the story is that he told me is maybe they don't liquefy over time. Maybe they're always solid up until the point that they're either removed or they just remain solid. I don't know. I don't know that we totally understand the natural history of these because nobody's really done a natural history study, you know.
Salma, you wanted to say something? Mustafa?
No, we're at 6:20 my time, but 7:20 and then 9:20. We've gone well over the sort of time that we had promised you we would keep you away from your family. Todd,
That's okay.
I really appreciate you sort of taking the time this morning to join us. I don't know if you had any final parting thoughts for the audience, but you know, I would say that this was actually very, very practical, and I like the simplified sort of classification, the ABCs. I think, you know, the more we can break it down, the better for all of us.
Well, you're welcome to use that, and I'm happy to send you my my presentation. But I want to just say to everybody, I appreciate the opportunity to speak with you, and I appreciate your attention, and I hope everybody has a safe and good evening. So, and thank you.
Thank you, and happy Valentine's Day to everybody.
Thank you.
So
thank you. You too. Okay.
Thank you very much.
Okay.
On behalf of Pakistan Society of Gastroenterology, Asian Endoscopic Cultural Group, and all the academia in Pakistan, we thank you for sparing your time and wish you a very happy life and safe from COVID. Happy Valentine. President, do you want to say something?
Yeah, thank you very much, Todd. It has been such a great pleasure to listen to you and interacting with us. And Pakistan Society of Gastroenterology is a very you know, had a long history and a robust society, and we would love for you to come to Pakistan and be with us in person when this COVID thing is over.
Okay.
Thank you very much.
I would welcome that. Thank you.
Thank you.
Okay.
Thank you, everybody. See you next Sunday. Take care. Bye-bye.
Bye.
Bye-bye.